everyone. I'm Representative Dr. Michelle Au. I'm a physician, a mom, and a Georgia state lawmaker. Welcome to the Georgia Diagnosis, a podcast that takes you behind the scenes of the state capitol to explore how policy really gets made and how it affects our lives. We'll talk with the people shaping Georgia's future and dig into the stories, the struggles, and solutions that define our state. This is the Georgia Diagnosis, where we take the pulse of Georgia politics. So this is the Georgia Diagnosis, and I'm State House Rep. Dr. Michelle Au. I think we've all heard the saying that a penny of prevention is worth a pound of cure, and I think there's nowhere where that's more clear than in the area of preventative health. So one story I often tell from my medical practice is that one time I was on overnight call for the OR, and we had a patient coming in at 2 a.m., as all good call nights go, with what's known as an aortic dissection, which is where part of the aorta is peeling away from the wall of the blood vessel. This is a true emergency. It's a real surgical emergency. And we rushed that patient to the OR immediately, where they were in there for many, many hours, receiving all manner of really catastrophic health care, including surgery, blood transfusions, needing medications to help her heart work better. And at the end of that surgery, we brought her intubated up to the ICU, where she needed continuous care for essentially another few weeks after that. I remember this case because this was a patient who was quite young. She was only in her 40s. She had a couple of young kids, not that much older than my kids, and she did not have health insurance. She was actually life-flighted in from a rural Georgia hospital where they were not equipped to take care of her. And for this condition in particular, I kept thinking that the one thing that really could have prevented this from happening is if she had had health insurance and had been able to be treated for the high blood pressure that almost certainly caused the aortic dissection in the first place, and how simply, 10 cents a day of taking a blood pressure medication could have prevented not just the catastrophic healthcare costs that were incurred by this uncompensated care, but also the cost to this family of seeing their mother up in the ICU for a month, needing this level of acute care. So today's episode is going to be about preventative care, and I'm so honored to have these two guests with me. We have Dr. Harry Hyman, who is a professor of health policy and a family medicine physician. And we have Dr. Teresa Rohrer-Kirchgraber, who is a professor of internal medicine. Welcome to both of you.
Thank you.
Thank you so much for joining me. So, we'll start generally. We're talking about preventative care today. Open-ended question, first of all. You both practice medicine in Georgia. You teach students. Yeah, you're part of that mentorship process of training the next generation of doctors. How are we doing in terms of our preventative care approach here in Georgia?
Oh my goodness.
Is this a leading question? Like, how's it going?
Boy. Piss poor, can I say that?
Sure.
In part because, we have to, get those patients care in the first place. And we see over and over again the worst case scenarios like the one that you described, or the patient that I saw with COPD or emphysema, basically, who the only reason we were able to see her was because one of the healthcare systems gave her financial assistance for 6 months so that she could get some things done. Mm-hmm. By that time, she's already got pretty end-stage emphysema. What if we were able to take care of her sooner? I mean, all those things are so important. Just being able to reach people, reaching them early, and let them understand the reasons for appropriate health care and early intervention.
Yeah, and I'll actually pick up on that. I mean, I think Georgia does as well on preventive care as it does in general, and I think most ratings were in the bottom 20% across the country in terms of access and our outcomes. And I think, kind of access to affordable, high quality healthcare is the bar that people have to get over to have access to preventive care. We have had one of the highest uninsured rates in the country for years. Mm-hmm. We're one of 10 states in the country that hasn't expanded Medicaid. So I think if you don't have access to health care, then by definition, you don't have access to preventive care. But I think we also have to take a step back because healthcare only drives about 20% of health outcomes. The greatest drivers of health outcomes are the social, economic, and environmental conditions in which people grow up. So, even practicing primary care, it's great to tell people, oh, you need to eat a healthy diet, fresh fruits and vegetables. You need to get regular exercise. And then when the patient looks at you and goes, well, I actually don't have access to affordable, healthy foods where I live, and come to my neighborhood, it's not safe to walk outside. There's no sidewalk, or there is a sidewalk, but after dark, it's just not safe. So I think we also have to broaden the lens to think about, well, what are those broader conditions that we collectively have a responsibility to provide to people to give them opportunities to live healthy lives.
I'm so glad you brought that up because, we were looking specifically at health outcomes for young kids, especially those young kids that ride diesel-fueled school buses.
Oh,
We know that when they ride those school buses and they have that exposure, their ability to do work academically is decreased. And at one point, I was talking to a legislator and they said, oh, well, that's really only in the city. I'm like, well, no, actually, if you're in a rural area, your ride is longer. So those kids are getting even more exposed. And again, by the time we see them in primary care, there's already been deficiencies going on, you know? So absolutely, it's what happens at the granular level, at their home level, that makes a difference. It's long before we ever get to them.
yeah, those social determinants of care, which I think luckily, one good thing that came out of COVID, if you can say anything good came out of it, is that we have more of a fluency around public health and how we talk about it, right? And, thinking back to the patient case that I referenced, one of the reasons I ran for office in the first place is that so many of the reasons that by the time patients get to me in the OR, it's too late to fix a lot of those problems. And even though we can take her to the OR, we can give her blood transfusions and bring her to the ICU and do all those things, but I can't fix those broader social determinants that led her to need that care in the first place, right? And those things, people always classically think about, obviously, access to health insurance or like costs of medications, sort of more intimately tied to the practice of medicine. But they're way broader than that, right? It's including access to like safe home environment, right? Food insecurity is a huge social determinant of health. Access to good education.
Early childhood education.
Right, exactly.
Transportation to allow you to get to work.
Right.
And to access full service grocery stores.
Right.
And the other things that you need.
Yeah.
Stable housing.
So all these things
A
live at the
critical
level.
determinant of
Yeah.
educational outcomes for kids and job stability for parents. So yeah, lots of factors outside the healthcare system. And to your point, one of the things that moved me from my primary care practice to public health was the recognition that the greatest barriers patients were experiencing towards living healthy lives were things going on outside of clinical care settings.
Right. And those things you named, I think people will classically think of them as the purview of the state government, right? And, working both in medicine and on healthcare policy, as you all do, really is hitting the work from both angles, because we really do have to zoom out in order to address those larger social determinants that make our patients sick.
Mm-hmm.
Yeah.
It's not just bedside medicine.
Yeah.
Right.
And that's one of the things that we are trying to kind of get across to our students early on.
Yeah.
Where I am, they start in the very first year with community population health, and they actually go to a number of different locations where they can work with people who have a need, who are uninsured, and actually really see what's going on. Because I think for many students, especially in medical schools, they most of them come from a higher socioeconomical status. And when you talk about food insecurity, they're like, what, they don't have a Mickey D's close by? I mean, they don't know that, they don't get that concept. But then when they can actually be there in their communities, helping and providing some care and recognizing that I can't just write a script. Oh, they can't just go to the pharmacy and get it.
Mm-hmm.
It's really useful. It's helpful for them to learn about that. But I also think it's a hard concept for them to really get about what those social determinants really are. They're kind of this idea, this thought process, but not really, they need to kind of like see it straight on.
Yeah. Not to be such a downer about it, but like, can you point to a piece of health policy that you've seen pass in the state of Georgia in the past couple terms, let's say, that you've seen in your clinical practice has made a direct difference for patients? Just to just show some of the things that government can and does do right sometimes?
I mean, I can think of the prior authorization bill.
Mm-hmm.
I'm grateful for that because before,
Explain what that is for our
so
folks again.
so when I would write a medication and the insurance company didn't like that one, they would say, no, you have to call and talk to, the insurance company in order to get it approved.
Yeah.
And even once you got it approved, say, for example, the difference between amlodipine, which is a calcium channel blocker we use for high blood pressure, and Norvasc, which is the trade name.
Mm-hmm.
I mean, if I chose one over the other, I would have to call and get a prior authorization, but then I would have to get that every 3 months. I'd have to
Yeah.
call again. And it's not just have your doctor call the insurance company, they'll disapprove it. It's 45 minutes on the phone of uncompensated time.
Yeah.
The bill made it so that I only have to do that once a year.
Yeah.
So, I mean, a little thing, but it makes a big difference in our practice if every 3 months I'm spending 45 minutes on the phone to get a medication approved that was already approved, that the patient was already using.
And I think that was our colleague, Dr. Kay Kirkpatrick, who helped
Right.
to get that bill over the finish line. So we're grateful to her for doing that. 'Cause
Yeah.
that's a real impediment to care, and people don't often know those details unless they're the ones who have to get their Norvasc prior approved, right? A chronic medication you've been taking for years that every 3 months you still have to say, like, I need this medicine is ludicrous, right?
I think stepping back at a higher level, I mean, obviously, health policy and healthcare policy is a balance of what goes on federally at the state level and locally. I think there are many people today that don't recognize that many of the preventive screenings they get, whether it's cholesterol screening or immunizations or cancer screening, are now for most people with insurance coverage free. With no out-of-pocket costs. I can tell you, as someone who's been around a few years, there were many years where I would recommend people to get a screening colonoscopy or a mammogram. They'd come back for a follow-up 3 to 6 months later. I'd ask if they'd had that done. The answer would be no, and I'd kind of turn to them and say, "Well, what's the barrier?" And they'd say, it's I can't afford it, doc.
Yeah.
And it wasn't for lack of health insurance, but with $1 and $2 and multi-$1,000 deductibles, that was a real barrier. Since the Affordable Care Act was passed in 2010 and implemented in 2014, those screenings for free.
Yeah.
I paid $1,200 out of pocket for a colonoscopy when I turned 50. When I turned 60, it was free. So that's been a powerful removal of a barrier, but you have to have insurance coverage to have access to those benefits. And so if you're uninsured, it doesn't matter that there's now federal requirements to provide those things for free. You still don't have access.
Right. That's often the trick with public health, right? Is we try to make it as easy as possible for people to do the right thing.
Yeah.
Right. And when we talk about, sometimes people you use that label about free healthcare as a talking point against expanding healthcare access. And what I continually remind people is that, first of all, it's not free, and we also don't often consider what the price is socially to the state, to the hospital systems, to practitioners, when we don't provide that preventative care, that the cost is actually much higher. But people don't feel it as much because it's not necessarily an individual cost. They're not getting a receipt for it like when they buy chicken at Publix, right? So it's a cost that's not felt, but it's astronomically high for our state.
And it's hard to measure. I mean, when public health works well, you don't see it.
Right.
When things are prevented, you can't count them. And that inability to be able to prove we're doing the right thing makes it incredibly difficult.
This is maybe a leading question because I have a sense of where you guys are going to go with this. But if you could say in one sentence, one preventative health policy that if you could pass it tomorrow, it would have the biggest impact in Georgia, what would you say?
Boy,
I know there's so many choices.
mandatory vaccines for childhood.
So we already have, we'll talk about that because
Yeah.
obviously vaccines have become a little bit more of a
Right.
hot button issue, inexplicably to me, one of the greatest medical advances in human history. I'm grateful that we are still having them required for public school enrollment for the most part, even though exemptions exist. But every year in the legislature, I see another bill that seeks to chip away at that requirement that actually keeps all of us safe.
I think the word mandatory
Yeah.
gets a lot of pushback,
Right.
but I think there is absolutely an opportunity in a way that maybe can thread a bipartisan needle to reduce the leakiness of our current policy. The current policy allows for medical exemptions and, quote, religious exemptions, but the religious exemption requires that you say, it's against my religion. It's that leaky. And in states that have narrowed that exemption in a way that respects religious freedom and acknowledges that people who have medical exemptions, the vaccination rates have been much better. The other thing I would say is, we've had a failed pathways waiver now for 2 years. When you enroll 7,500 people out of 250,000, and the state government's own data says that 65% of those are working part or full time, clearly you have a policy that's not achieving either its work-related goals or its coverage-related goals. Our number of uninsured is only going to go up as the federal subsidies on the marketplace are pulled back through this last beast of a bill. So we've got to do something to ensure people get the coverage they need.
Well, the one good thing, if we can say anything good about the Pathways program, is that at least we acknowledge that it is a good goal to get more uninsured people health insurance. So I think we can agree on that. So starting from where we agree that a good goal moving forward would be to make sure that this policy works better to actually serve the Georgians it is intended to. One of the things that stymies that goal is, in fact, the work reporting requirements that give a lot of bureaucratic hurdles to patients accessing care. But I'm gratified that we at least agree that it's good to cover patients so they can get the preventative care that they need. Thank you both so much for being here. I really appreciate your expertise. I always know I have expert consultants I can go to when I need advice at the Capitol, and I hope I see you guys in January when we get back.
We'll be there.
Thank you.
Thank you.
Okay, so I'm here right now with Dr. Barbara Marston, who is a physician with internal medicine training specializing in infectious disease and who retired from the Centers for Disease Control in 2022. So Barbara, we had talked about you coming on this episode to talk about preventative care and healthcare policy a while ago. And in the time intervening, we have something new to talk about, especially with respect to the CDC and with public health systems at large. I'm sure you've thought a lot about this, but after the shooting at the CDC a little more than a week ago, we've discussed a little bit about how political discourse has colored how people approach public health and the sort of perpetuation of mis and disinformation around public health systems and preventative care and interventions that has led to what I would frankly classify as a pretty dangerous environment for many of us in this field. Can you talk about your thoughts?
I think that's absolutely right. Maybe we just start with like why people in public health or preventive services do the work they do, and it's important to understand. I think we have shared values with pretty much everybody, which is we want as many people as possible to be healthy. We want the kids to be healthy. We want people to lead comfortable, productive lives. So having the work that we do to try and achieve that objective thought about as something that's bad for people is a very difficult thought to digest. I think with the CDC shooting, there are a few things that are clear, and there are maybe three big contributors to it from my perspective. And one of them is vilification of public health workers. They've been described as lazy and wasteful, and I can tell you they're the opposite. In my time at CDC, people were very, very hardworking, very dedicated. I'll never say that everything we did was perfect, but I can tell you that is what people were trying to do is the very best. So I think describing public health workers as maybe enemies is a tragic thing to do. And then the vilification of public health interventions, those are also, I think, underappreciated for a couple of reasons. Vaccines, for example, now people are making decisions about vaccines based on, shall I take a vaccine given that everybody around me is vaccinated and I'm not at risk for this disease now, as opposed to back when they were used to seeing polio or measles and they could really make the proper decision, which is what's the balance between the vaccine and the disease. And to see vaccines be given a bad name. I mean, again, vaccines aren't perfect, but they are an incredible health intervention. They've taken us from having a situation where many, many families lost children to a situation where that is exceedingly rare now. And just an enormously important intervention. And I think the misinformation about them is a terrible disservice. And then I think the availability of guns. So you put those three things together and take a troubled person who has believed what he's been mistold about federal workers and vaccines and the availability, and he's got access to guns, and that makes for the kind of tragedy that we saw last Friday.
I think that this type of outcome or this environment being fomented is something a lot of us were worried about when we saw that RFK Jr. was the one who was nominated to be the Secretary of HHS, who oversees essentially the entirety of the American public health system, right? And there are many things about which I would be delighted to be wrong. Obviously the investigation into the CDC shooting is ongoing, so I don't want to comment on that case in specific, but I think that in general, it's fair to say that with a history of promoting really not scientifically based anti-vaccine rhetoric, and quite frankly, having explicitly vilifying language around those who seek to keep our kids healthy in promoting our vaccination programs, is something that's very dismaying to people who have devoted, like you, your entire working lives and your careers to that task of keeping our communities healthy, right? You're not at the CDC anymore, you're retired, but can you speak a little bit about the morale in the public health space, especially with this new administration taking the approach that it does?
Sure. I think I'm pretty aware of the morale. Obviously, I have a lot of friends and colleagues that are still there, and I'm one of the things I'm doing in retirement is coordinating a group of previous CDC staff members, and so we are collectively in touch with quite a number of people who are still working there. We call them badge holders. We've been coordinating the rallies weekly outside of CDC, and we have two main purposes of those rallies. One is to make sure that there's media attention to what's going on, but the other is really to lift the spirits of the people that are working there. And you see, when you see our rallies, they have a lot of, thank you, CDC, for doing these things, or support for the workers. And we do hear from quite a number of them that is helpful in lifting their spirits, like seeing that there are people that appreciate the work that they do. It's, I think most of my colleagues and friends, virtually all, went into public health thinking this is an opportunity to do something that is at once interesting. It's science, it's science applied, and it's fascinating from that perspective, but it's also an opportunity to do good, and people are driven by that mission. And then to be misdirected in that mission is an exceedingly uncomfortable thing. People have to figure out what line would they not cross if they're asked to provide information that's not scientifically valid, or if it's not in the best interest of the population that they're really meant to serve. So I think that's, you take away the thing that drives you to do the work. That's the worst thing you can do for morale. And then to add a concern about personal safety on top of that wasn't people's, top concern before Friday. And even when you talk to the people who have lost their jobs, and obviously that's a personal concern, but when you talk to them, sure, they're worried about that. But the first thing that they mention is their concern for the agency and what's happening to the agency, and their concern for what's happening to public health and what will be happening to health of Americans as a result of some of the changes that are being made.
Right. And these changes, even though they're acute in that the types of cuts are acute and the incidents are immediate, that the lasting effects may in fact be generational, right? Like these effects don't
Sure.
just evaporate
No,
if you
no.
turn the funding back on,
Right. It's
or you
much
hire
much
people
easier.
back.
Right. Much easier to destroy than to build up. And you know, again, CDC's not perfect. Not every program was highly effective, but that's the effort. You know, when you think about, a lot of people don't understand what CDC does. So I don't know if I can talk about that for a second. But again, the main goal is to improve the health of Americans. But how you do that is maybe 3 different buckets of activity. So one is surveillance. You track diseases and who is getting them and who's at risk for them. And that's an important body of work. People expect to be able to answer questions like, what is the rate of diabetes in America? That kind of thing. And then you do science, which is you try and figure out, okay, well, what works to prevent the problem or to ameliorate the problem? And then you do service, which means you implement the programs that really take that science into account and make the difference in people's health. And I think a lot of people don't realize that about 80 cents of every dollar of CDC's domestic funding goes to state and local health departments, and that is to implement public health programs that have been proven. And a lot of these programs are highly, highly effective. And you know, there's a lot of talk about, oh, people can take personal responsibility for their own health, but actually there's a lot of things that are better done at a community level. Like you talk a lot about smoking. Let's talk about secondhand smoke, right? An individual can try and avoid secondhand smoke, but think how much easier that is to do if restaurants have non-smoking sections or non-smoking policies, or if parks and public buildings have just those interventions are highly effective at the community level. And that's the kind of thing that public health does, as opposed to the individual care that physicians provide. And I think, you know, one of the difficulties for us in public health has always been to explain to people what we do, because so much of it is prevention and so much of it is therefore invisible. You don't wake up every day thinking, my food was safe. You
I
know,
don't have cholera.
you don't have cholera,
Yeah.
right? I didn't run into secondhand smoke at the restaurant, you know, because it's hard to imagine things that didn't happen. One way we can do it is to look back before, you know, interventions were implemented. So look back before the Haemophilus influenza B vaccine was available, to a time when, you know, 1,000 kids died every year. Kids had epiglottitis. You probably are too young, but, you know, in the day, there were epiglottitis, you know, response teams that had to run when a kid couldn't
I've seen
breathe.
one case.
Right.
That's because
So-
I trained in pediatrics in the early 2000s. So, you know, we didn't have a case of the measles ever. I'd never seen the measles.
Right.
That's maybe not something that pediatrics residents get to see now.
But people that can remember those things really can see the, you know, the impact of public health interventions. But I think we've been away from measles and polio for a long time, and people are maybe complacent and worrying about other things. But I can assure your listeners that we don't want to return to those times.
Yeah. You know, I often think of public health and the approach there as similar to voting in a way, right? And even though we can take personal responsibility, and that's always important, but much like voting, the approach to public health is a collective action strategy, right?
Mhm.
And just to tie it down to one thing we've talked about, which is vaccination rates, right? Like, of course, any individual patient, any individual family can choose to vaccinate their child, and that's good, and I encourage people to do that. But really how it works the best is to achieve a certain percentage of vaccination in the community, because then if the immunization levels drop below a certain threshold, that even if I personally choose to get my children vaccinated against the measles, it doesn't hold as well, it doesn't work as well to contain measles outbreaks as if a threshold is reached, right? So that's, I think, one of the challenges of communicating in public health, that it is a community-based approach, not an individual approach. And that can be difficult to convince people of, because people do often tend to think in units of their own bodies or their own families. And why should I care about other people? But, you know, that's the essence of a civilized society, is you care about other people, right?
Right. Vaccination is a perfect example of that. So, you know, every decision you make is a balanced decision, but what people should be weighing is not just their current risk of measles versus whatever they are concerned about with vaccines, which, by the way, I would still make the decision for the vaccine, especially for the measles vaccine, because it's extraordinarily safe. But that whole idea that we need the whole population to have
Right.
protection for the population, for everybody in that population to be protected.
Right. And not only is the measles vaccine extraordinarily safe, that's been demonstrated over decades, but it is also, the measles virus is among the most infectious viruses
Right.
on the planet, which I think people also
Right.
don't appreciate is what a coup it was to get that vaccine developed. And now it's essentially an unknown disease to many.
And there are several, like take smallpox, right?
Yeah.
Smallpox has been eradicated because of a highly effective, very safe vaccine. And again, we don't want to go back to those days.
The bad old days.
No.
No,
Right.
I don't want to go back there either.
Yeah.
Well, I know it's a discouraging time in the public health field. I obviously work at that interface between clinical bedside medicine and public health and health policy, right? So it is a very challenging time, but we will get past it. The work goes on, and so do we.
That's right.
And I really want to commend all the work that you and your colleagues do to ensure that we are all still here to do that work because our patients need us.
Thank you.
Thanks so much, Barbara. Appreciate you being here.